Dr. Broussard, I am so excited to have you with me today. Your experience is going to resonate so much with my audience. Let's start with what led you to become an embryologist in the fertility world?
Hi, yeah, thanks so much for having me. So it's actually really interesting. I have kind of a unique background that probably not very many people in New York City will tell you, but I grew up on a farm in the Midwest. And so my background comes originally from working with our farm animals. And so back then, we actually did a lot of embryo work. So we're talking way back early 90s. We did a lot of embryo work and then, of course, doing things like what we call artificial insemination with our animals. And so that's what actually really got me interested. I was from a pretty young age very interested in the reproductive side. And so when I originally set out kind of picking a career goal, I originally wanted to be a veterinarian and wanted to work on that side of things. But once I actually got into college, I went to Purdue for undergrad and started kind of exploring my career options and found out that I could work on the human side of things. I found out that that was actually a lot more rewarding and a lot cooler. So I ended up kind of, redirecting my path from more of the animal side of reproduction to the human side. But at the embryo level and, kind of at the basic fundamentals, it's really very much the same. So we actually rely a lot on our animal friends to kind of teach us a lot that we know today. And that's where a lot of embryologists actually get their initial, hands-on learning skills and where we do a lot of our research. So I on the animal side and then made my transition over to humans. So
That's so interesting to hear what inspired you to become the embryologist. Tell us a little bit about the breakdown of your role.
okay, so I'm currently the laboratory director here at Generation Next. I actually started off my career as an embryologist. So the first 15 years of my career, I spent actually at the bench doing the embryo work. And so during that time, I was actually doing, and which has certainly evolved over time. When I originally got out of graduate school way back when, the field looked very different. We weren't doing the amount of genetic testing on embryos that we are now. We were doing mostly fresh transfers. People were just starting to work with, even day 5 transfers and blastocysts. Really, things evolved quite a bit. We didn't have vitrification, which is how we currently freeze embryos and oocytes. Things were a lot different. But I spent the first 15 years at the bench working full time, and then eventually really became more passionate with the other side of things, which was really working directly with the patients and also mentoring and really being able to kind of work with people who were starting out their career. And that's what became a little bit more important to me. And, I started to want to kind of move away from the bench and want to focus more on kind of more the administrative side of things and getting to kind of make decisions about what kind of equipment we're going to put in the lab and what we want to have for culture and what we want to have to offer our patients and also to be able to talk to patients about their treatment plan and even what's going on with their embryos in the laboratory. And that's what led me to want to go back to school and get my doctoral degree and then become a laboratory director.
Amazing. So, the relationship between the patients, the doctors, and it takes an extremely dedicated and caring person to be in this role. How do you communicate both the difficult and the good news?
Yeah, I mean, it definitely is something that you learn. I sometimes kind of joke that I'm good at bad news, but I'm also good at good news. And but you do have to kind of learn. I think what's really important is first of all, always staying compassionate and really do having a really big compassion and understanding for what the patients are going through. And I think, just as a woman and has somebody who, I have children myself and everything, and just having someone who's always really valued that reproductive part of life and knowing how important it is to build a family. I never lose sight of that. And so I always have that part of me that understands what it's like. And I've had so many friends that have gone through IVF. I've done IVF on a lot of my girlfriends. I've been the first babysitter for some of my best friends' embryos. I've done embryo transfers on some of my best friends. So, I've been through this with a lot of my friends over time and I've been through this journey with so many different women that I've become friends through this journey. And I think that for me I always make sure that I really keep in touch with understanding what the women are going through and how important this journey is has one, really important part of it. But then on the other side of it, really being passionate about the science piece and having a good understanding and being able to, first of all, teach embryologists and people in the laboratory about the science, but also being able to educate the patients about the science. And so I think the best way that, I kind of can handle the bad news is being able to, first of all, really keep track of what the patients are going through and really being compassionate about that and having a lot of empathy for that, but also having that using that as kind of like a teaching moment. There's so many times that I talk to patients about some really not great news, but through that I'm able to say something that we learned about their oocytes and their embryos and their partner's sperm that they say, this was really educational for me. Nobody's told me about this piece of our infertility journey. Like I know this wasn't a great outcome for us on this cycle, but we just learned a lot from this conversation. And so I think that that has what has really kind of driven me to kind of enjoy that part, if you can say enjoy that. But I know that's a difficult part of my job, but I also really do enjoy that role because I think it's really, really important for the patient that we're able to educate them and be able to talk about even when it's not a great conversation, because that's how we move forward with the progress and we make the next best decisions and we figure out next steps so that they do eventually have that success.
What an amazing role you have, and it's like, doing a fine line dance, and it's a balancing act. You're so dedicated and caring, and yet there's no room for error. How do you keep
Right.
track of each embryo?
So, I mean, we are very, very strict on our double check process. So, every single thing that happens in our laboratory, from paperwork to emails to certainly anything that happens at the bench, is a two-person check process. And so, because we keep everything very separate and compartmentalized, we have a lot of physical separation as well as a lot of double checks. And so that's how we keep track of things. So when I say compartmentalization, so for instance, workstations, when we're working with embryos or we're working with the sperm samples, we have individual stations that we're working in where there's only one patient's embryos out or one patient's oocytes out or one patient's sperm samples out in that particular station. Then as far as the incubator, the compartment in that incubator has only has one patient in it at any given time. So we keep things very isolated as far as like on a per patient. We're working in what we call like a hood that has a microscope in it. We're only having one patient open in that hood at a time. And then every time that we pull a dish of embryos out, we have a more senior person pulling out a dish. We have someone that looks at that dish right at that exact same time, and they both verify all the information on there. So before, embryos get moved from one dish to another, there's two people that are looking that everything matches. When the patients are brought into the room, there's double check verification between the embryologist and the patient, between the other people who are working in the room, the physicians, the clinical assistants, anyone who's in the room working with the patient, that things are verified. Even when we put the male partners in the room, two of us go to the room and we verify. We have them, show us their ID, verify their information, their partner's information, and then both of us at the same time with that male patient look at their information on the cup, and we make sure that there's always a double check at every single step along the way. Even when we label every single straw that the little embryos are frozen on, when we do an embryo biopsy for genetic testing, every single tube is labeled. There's always a two-person process. Even when we store things in a tank or take things out of a tank, it's two people at a time. So we always have a check and balance system to make sure that every single step along the way is precise and that there is, checks and balances to make sure that there's no room for error along the way.
Strict standards, no doubt.
Mhm.
With sperm quality, you can test and see the fragmentation, but with egg quality, is that easy to test?
I mean, sperm and egg quality both are a little bit tricky. So sperm, they can be a little bit more straightforward. You can look at, motility, count, things like that, and there's millions of them, right? So you can kind of sort through and pick your favorites. And there are more in-depth tests that you can look at, like you mentioned, DNA fragmentation. But even that, we can't look at a sperm and know if their DNA is fragmented right there at the bench top when we're selecting it for like ICSI for sperm injection. For oocytes, it's a little bit trickier. There we do know from just looking at oocytes over time there's certain kind of like physical morphology we call it, or like attributes that we're looking at that would kind of indicate to us a healthier egg, certainly if it's mature or not, but kind of like the shape and just certain characteristics that we do make notations that we do associate with being a healthier oocyte. But at the end of the day, we really don't know how healthy an egg is until we fertilize it and we watch it grow and develop. So even though I tell patients all the time that even though at the time of ICSI, our embryologist will make notations that says, we noted that maybe the membrane integrity was soft of the oocyte, meaning that when they did the ICSI, the membrane was really soft, or they noted that it was kind of granular in texture. That those are notations that we make, but an egg that looks like that, or that we noted soft membrane integrity, it can grow develop into a beautiful blastocyst and make a healthy newborn baby. So it doesn't necessarily mean that's 100% indication of the egg quality not being good, but it's notations that we make as embryologists that we know can be associated with maybe good or poor egg quality. We do have a new option that's available to us that's more kind of at a research level at this point. So we do have a consent that we have patients sign for it, but it's something that we just started having available. I know patients have probably heard us mention talking about our time lapse incubator with Chloe technology. We do have oocyte quality has a feature now, which is where we can put oocytes in the incubator, and they actually do use their technology to give us an indication of oocyte quality, which means predicting blastocyst quality. Now, again,
Mhm.
this is still at kind of a research level for that particular feature. So that is something that we're starting to introduce as an option to our patients, has, something that they can consent form that we can kind of gather some data on. So kind of that using that AI technology to kind of help us learn more about our oocytes through their machine learning that they've done at their company. So that's something that we're starting to have available to us, that kind of more of a just starting to be available to our patients. But at the end of the day, the best way for us to know what oocyte quality really is to fertilize the oocytes and then see what happens.
So, talk us through what is PGT testing? What are the pros and cons of PGT testing? And when I was going through IVF, I was actually scared because I had a
hmm
limited amount of embryos and I was just, didn't want to risk anything, any damage, but that's just all myths. Talk us through the steps and the pros and
Yeah.
cons.
So there's different types of testing that we can do. So when people generally talk about pre-implantation genetic testing, they're usually talking about for aneuploidy. So that's kind of the most like overall basic one. So PGT testing for aneuploidy is looking for chromosome count. So that's
Mhm.
looking for does the embryo have the right number of chromosomes. So from that you're going to find out whether it's having an extra copy of one chromosome or missing a copy of the chromosome. So that's kind of the most common reason that patients may have embryos that failed implant or may miscarry as chromosome abnormalities. So that one is just kind of like a one size fits all, doesn't need any pre-planning. So the pre-implantation genetic testing for that is just anyone can do it. So basically how that works is the embryos are fertilized, we grow them for between 5 to 7 days in culture. And when they're at the blastocyst stage, so the embryos are probably around 150 to 200 cells, we biopsy off about 6 to 8 cells and we send that little bundle of cells off for genetic testing. That's kind of the most straightforward way. There are other tests that we can do that are more kind of advanced or more specialized for patients who need other things. So some of those might be structural rearrangements. So SR, that's not very common. That's for patients that find out that they have a translocation. There's also monogenic testing. So all of our patients that come through for fertility tests for fertility treatments with us will do some genetic testing as part of their initial fertility workup. And there are a good number of patients that find out that they're mutual carriers for a genetic test that they didn't know about. So, like a common one that people might be aware of is cystic fibrosis. So, if the couple finds out that they're both carriers for cystic fibrosis, they have they have a chance of either their embryos being affected by cystic fibrosis, being
Mhm.
carriers of cystic fibrosis,
Mhm.
or being unaffected. So we would develop a probe or have kind of a probe tested with a external company that can look for their particular mutation of cystic fibrosis, and then we can test all their embryos to see if they're affected carriers or not carriers of cystic fibrosis. And then that's just one example. And that would be something that's very specific to them. So those are kind of the more typical ones. We also have something called embryo quality score, which is through genomic prediction, one of
Mhm.
the external lab partner that we work with. That one is a little bit more unique. That one looks at it's kind of it's polygenic. So it means that They're looking for there's a whole list of tests that they a whole list of different conditions within the embryo that they're looking for, where they can say, like, this embryo is more at risk for having like heart disease. This embryo is more at risk for having, I know schizophrenia is on the list. I can't remember everything that's on the list off the top of my head, but there's different, different polygenic, meaning that multiple genes are associated with a condition, and they're able to give us a risk score for a patient's embryos to say which embryos are most likely to be affected by, such a condition that they know runs in that couple's family. So
Mhm.
those are kind of some of the tests that are available, but the most common one is the PGT-A, has what we call sort of for aneuploidy, and that's the one you would have been talking about.
Yes.
And we do that a lot. I would say probably nowadays, probably around 80% of patients use some sort of genetic testing just for aneuploidy.
Hmm.
Um, and the reason for that is it does help to get to that successful pregnancy faster. What I mean by that is by screening the embryos ahead of time, you're able to know which embryos are most likely to implant and make a healthy pregnancy. Now, just because the embryo comes back as genetically normal, it doesn't mean that it's going to 100% result in a live birth. But it does mean that there's a lot greater chance that it's going to implant and result in a healthy pregnancy and a live birth. So it just decreases the time to a healthy pregnancy and a healthy live birth. And so that's why a lot of couples choose to, proceed with that particular technology. As far as for safety for the embryos, it's very safe. I tell people it's a little microsurgery. My embryologists that do that every day in the laboratory, it's a very, it's a very skilled type of little microsurgery, but it's just taking off a little bundle of cells off of the part of the embryo that would not the part of the embryo that would become the fetus, but the part of the embryo that would implant and become part of the placenta. And so
Hmm.
they can biopsy a little bundle of cells when the embryo is, a pretty good size, and it doesn't affect the actual embryo itself. It's nice and safe, and it's like a little routine surgery of us going and having something like going to the dermatologist and having something, some skin cells taken off. It's kind of like the same thing for the embryo. It's like a little procedure for the embryo that's completely safe, and then it gives us a lot of information about the embryo.
Good to know. So there's so much information out there nowadays. What are the advantages of a fresh versus a frozen transfer?
Yeah, so there's still advantages to both. So we used to
Hmm.
always do fresh transfers. So back in the earlier stages of my career, everybody did fresh transfers. And the reason for that was we were not very good at freezing embryos. So before we had really good success with vitrification, we didn't freeze very well. So before we were able to do that, really the best option was to grow the embryos fresh and do a transfer. And that was your best chance of success. So there are still patients that with freezing now, we usually have 99% survival with freezing. The embryo freezing is very, very good. So there are still advantages to freezing, even if you don't do genetic testing. Now, if you do the genetic testing that we just spoke about, you do have to freeze the embryo because the genetic tests do take a while to
Hmm.
come back. So the
Hmm.
embryo has
Good
to be
point.
frozen in the meantime. So if you're going to do any sort of genetic testing, you have to do the freezing. Now, there are other advantages too. Sometimes when we're optimizing the cycle for the patient to get the best eggs from her ovaries, we're not necessarily making the best uterine environment. So there have been studies that have shown that if the hormone levels are at such levels during the ovarian stimulation process, that may
Hmm.
not be the best environment to then put an embryo back in for implantation and for pregnancy to begin. So
Hmm.
sometimes there are advantages to freezing the embryo and then coming back a month later, 2 months later, whatever they decide to put that embryo back at a time that's more ideal for the embryo. We also have a lot of patients that do bank embryos.
Hmm.
So a good population of our patients are older here in New York City, and they do want to bank embryos. They want to have a certain number of embryos frozen before they actually become pregnant. And some are actually just doing family planning. They don't want a pregnancy yet. So they're freezing their embryos that they're going to use in a few years from now. They just want to make sure that they have them frozen so they can continue on with their career. They can, you know, do whatever they're going to do in the meantime. And so there's less advantages to putting those embryos literally away in the freezer and then coming back for them when it's the right time in their life for those embryos as well.
Sure. So I know you touched upon it when we discussed quality control, but how do you mitigate risks in the IVF labs?
Yeah, so I mentioned all of the kinda, like, checks and balances as far as, like, what we do on a day-to-day, but as far as just, like, kind of the overall things, there's so many things that happen as far as, like, equipment
Mhm.
like so we have first of all, just as far as, like, alarm systems. So all of our incubators and our liquid nitrogen tanks that we store our frozen embryos and oocytes and sperm in, they all have alarm systems on
Mhm.
there. And they're also under, secured areas that you have to use a passcode to get into. We have everything under camera surveillance. So we have multiple different like surveillance levels where things are being monitored 24/7.
Mhm.
Um, as far as the actual like temperature and alarm systems that I spoke of, we have people on call 24/7, 365 days a year, where somebody is always paying attention to those alarms. And if anything goes out of normal as far as like the gas levels in the incubators or the temperature levels or anything, then we have ways that people will immediately be able to log in and check what's going on, and then people that will respond right away and be able to go ahead and do whatever needs to be done to fix things. The incubators themselves are pretty like stable environments that there is a little bit of room for, let's say that something happens with a gas level, there is a little bit of kind of like time in there where the embryos are protected, in which that gives us enough time to come in and intervene with whatever we need to do. The liquid nitrogen tanks are actually, even though we're checking them for temperature, we actually measure them physically every day, and we top them off every day as far as liquid levels. But
Mhm.
the liquid nitrogen tanks themselves that they're stored in, they don't even need electricity. So they're literally containers that are filled with liquid nitrogen. So in the event of something like a catastrophe where, we had some issue where we couldn't get, power or liquid nitrogen or anything into New York City, we would have weeks and weeks before specimens would ever actually be at risk for those
Mhm.
tanks to go
Mhm.
above temperatures where the
Mm.
embryos oocytes that are frozen would ever be affected.
Mm. Good to know. How many embryos should be transferred for the best chance of success?
So it really depends on a couple of things. So, number one, generally when it's a genetically tested embryo, no matter the patient's age, if the embryo has been genetically tested, it has what we call euploids. So we've done the pre-implantation genetic testing, and we know the embryo has all the correct number of chromosomes, then we pretty much always recommend one embryo. Pregnancy rates are actually very similar whether you're 44 or 36 if we get to the point where your embryo has been tested genetically normal. So the challenge is whether you're 36 versus 44 is getting the genetically normal embryo. As we get older, our chance of having abnormal embryos, so abnormal number of chromosomes, does increase. So as you get older, your number of abnormal chromosomes does increase. So over 35, it starts to incrementally get higher and higher to have abnormal embryos. So
Mhm.
especially as women get over 40, that goes even higher quicker. So, but once you actually get a genetically tested normal embryo, your chance at actually getting pregnant is pretty similar to someone who's much younger with that same genetically tested embryo. So if it's a genetically tested embryo, we pretty much always recommend one embryo. If the patient is not using genetically tested embryo, again, because of the genetic abnormalities and because most embryos that are genetically abnormal just will fail to implant, um, we will transform more embryos.
Mhm.
There are ASRM guidelines. So ASRM is kind of like our
Mhm.
governing body that we use
Mhm.
their recommendation, their guidelines to make decisions.
Mhm.
So there are guidelines that have to do with the stage of the embryo, whether the embryo is a cleavage stage embryo, so like a day 3 embryo, or
Mhm.
whether it's a blastocyst embryo, so like a day 5, 6, 7 embryo, and the female, whoever the egg source, so the female's age, that tell us the guidelines for transferring embryos. There are, of course, other things that do come into play, as there are reasons that this female should not have multiples, that she would be at higher risk for having multiples. Um, is this patient, what is her history? Does she have a history of, being pregnant multiple times? Even though this woman's 40, did she just get pregnant on her own a year ago? I mean, some of those things would come into play as far as making decisions, but we do follow those guidelines pretty strictly. And because we genetically test the embryos, that does allow us to kind of make easier decisions for our patients as far as numbers.
What is the difference between a day 3 or a day 5 development in an embryo? Talk us through the development.
Sure. So day three embryo is going to be around an 8 cell embryo. So
Mhm.
it's actually really interesting because so day zero is considered like egg retrieval day or fertilization day.
Mhm.
So the way that development goes in the lab is day zero is egg retrieval day, fertilization day. Day one is when we do fertilization check. And so the first few days of embryo development are actually, I always tell the patients, they're actually pretty boring and pretty slow. There's not, it's a very slow development those first few days. So day zero is an egg. Day one is going to be a pronuclear embryo, so where we see the signs of fertilization. And towards the end of day one, we'll start to see it around a 2 cell. So day two, we would see around a 4 cell on average. And then day three, we're going to see around an 8 cell. So those first 3 days of development, you figure the embryo is only going to make it to around an 8 cell stage. So that's kind of slow development if you think about it. Well, once we hit about that 8 cell stage of development around day three, the embryo really kind of takes off exponentially in growth. Then
Mhm.
we start to see growth go a lot faster. So if you think about it, an embryo goes from being around 8 cell on day three to by the time we're talking about blastocyst for biopsy, which is somewhere between day 5 to day 7, we're talking about 150 to
Wow.
200 cells. So that's a huge growth difference
Exponentially.
between, day zero to day three being 8 cells, and then day three to let's say day six being,
Amazing.
150 to 200 cells. So it's a huge difference in growth. So the
Is
the real difference I would say though, as far as like the difference in developmental kind of, I always say the reason that one of the biggest kind of jumps in progress our field made in embryology, and this was kind of happening right around the time that I got out of grad school way back in the early 2000s, as people were really starting to culture embryos to the black stage. And so the reason that we saw pregnancy rates just hugely increase at that point was because a lot of embryos will make it to a pretty decent day three developmental stage. I always tell patients it's not that difficult for the embryos to make it to somewhere around an 8 cell. At that point, kind of maternal genes are growing. I always kind of like to think of it as almost like autopilot for the embryos. It's pretty easy, pretty straightforward to get to day three of development. But day three of development and on, that's where the embryo's little genome activates. That's where the embryo really takes off and kind of like shows us what it can do. And I always tell patients that, even if you're, 32 years old and let's say you have 6 embryos that look exactly the same on day three, and they're all like really pretty 8 cells, let's say, for instance,
uh-huh.
those 6 embryos are not going to look the same on day five. You're going to
Mm.
have some that look better than others. You might have, one or two that don't progress at all from day three to day five. It's very common for embryos to arrest around the cleavage stages, and that means not continue to grow. So there's a lot that happens from that day three to the blastocyst stage, and that's why I really do like to make it to the blastocyst stage. I like to do the extended culture when at all possible, and there is a big difference in just kind of like what we say developmental potential or pregnancy rates from that day three of development to the blastocyst.
Is the egg or sperm responsible for the low fertilization rate?
It can be both. So sometimes it's difficult to know exactly which, but it certainly can be both.
Mhm.
We used to blame the oocyte for everything. I think in the earlier days, and
Mhm.
we do more know more about the sperm. There definitely is a lot that the sperm contributes. And it can definitely be both, and it can definitely be one or the other. It doesn't necessarily have to just be one. And we see that with interesting things where, like, let's say we have a couple that has had some fertility or some fertilization challenges in the past, and then they decide to do donor oocytes, and then we still see fertilization challenges using that same partner sperm with donor oocytes, which presumably should have a much easier time fertilizing. So yeah, it's not always just the oocyte. It can be the sperm, and it can be a little bit of both. So yeah, it's not necessarily just one or the other. Same thing for embryo development. It's not necessarily just the oocyte or just the sperm. The one thing that I do always say is, we try to come up with some ways in the laboratory to really select our sperm because we don't have the advantage of being able to select oocytes very aggressively. So, as us women, we're born with already losing our oocytes. Before we're even born, we're already losing all the oocytes that we've originally had. So I think it's around like week 12 or something like that of pregnancy. We've already had the maximum number of oocytes we're ever going to have in our life. And so by the time we're born, we're already losing oocytes. So for men, they're always making sperm. So even if they have some sperm that's suboptimal, as embryologists, we can use different tricks and tools in the lab to kind of sort through them, hand select them. There's always typically way more sperm than we ever need to work with, as opposed to a limited number of eggs. So we can do
Mhm.
different things to kind of select our sperm and aggressively choose which ones we want to use to inject into the eggs. But we unfortunately don't have that advantage with the oocyte. We have a finite number of oocytes that we're ever going to be able to use.
Good to know. Can you give some tips to navigate the 2-week wait?
Oh, that's a tricky one. I don't know that there is any good tricks for that. I think that that's a challenge no matter whether people are trying on their own, whether they're going through infertility treatments. I think that that's a challenge no matter what, because, I know even in times that I've been through that in my life, it's like you think of like anything in your body that has for signs whether it was successful. And we all know that many of the signs in our body that are could be an our upcoming period also look very much like early pregnancy. So it's very, very tricky to try to wait. And I don't think there's anyone in the world that can make you say like, oh, just be patient and try to
No.
relax. I just don't know that, and I know I'm not a patient person, and I know I don't necessarily know how to relax that well. I'm getting better at it as I get older, but I'm not very patient. I don't know how to relax very well myself. So I don't know that there really is a good way. I would say honestly, my best advice is that I do kind of like enjoy reading things on the internet, and I do watch people like silly, like when I take the train back and forth to work, I watch all these couples that are going through fertility treatments and stuff just as kind of like, it's just kind of fascinating to like see the other side of it. And I would say the number one thing is don't listen to everything you hear on the internet, because I hear so much misinformation, and I
Exactly.
do see where people kind of like make other people panic because they say what their story was, and their story is really unrealistic, or they say like, oh, like this could, they make people worry about like, oh, this could be happening to you, or things like that. And I would say as much as you can, try not to read stuff on the internet, try not to get
Good.
misinformation from people who are, kind of like internet experts, if you will, that are not experts. Because I read stuff online and I'm just like, that is really not accurate information. If I were a patient that was going through it, that would probably make me kind of worry and panic. So I would say as much as possible, try to have faith in whoever you choose for your care team, and, find ways to kind of self-care and take care of yourself and in your life. Maybe I would say try to surround yourself with friends that are going through it. I know that can be really challenging for women, especially when they have friends, sisters, et cetera, that are maybe getting pregnant really easily and, not going through infertility problems. But I can guarantee you from the standpoint of, obviously my age group is kind of older now, so none of my friends are really, now I'm kind of moved to the point where my kids' friends are not, their parents are not going through it and things. But there was a point in time there where I always knew that there was a lot of people going through infertility, because I could go to any dinner party and I didn't have to know a single person. But as soon as like it came to the topic of what people did for a living, as soon as I said what I did for a living, there would always be a couple heads that snapped over to me. And by, an hour into the party, there would be random people who would like isolate me out and want to talk about it. And it always made you very aware of just how many people out there were going through it, and probably other people in their life didn't
Mhm.
know they were going through it. And so I would say my best advice is to find people going through it that you can, have those friendships with and just connect with, whether it be a support group, or I can guarantee you know other people, whether it's at your gym or at work, or, in your family or something that's going through it. And to have those people who is kind of like your support system, I think is probably the best way.
Great tips. Love it. Community is everything. What are some myths that you think need to be busted when it comes to embryology?
I think that there's always the thing that always like worries me is that people, and this is what I see online every once in a while, people will hear like one bad story about something that happened,
Mhm.
and that will become like something that people really worry about happening to them. And to
Mhm.
be honest with you, I've been in this field for a long time, and the embryology field is small. I always joke it's like high school. There are not very many of us. It's like, what is that? who's the one actor, Kevin Bacon, where they always say like how many degrees of separation from Kevin
Right.
Bacon? Well, in the embryology world, it's like about 2 degrees of separation. You can't like talk to anybody else in the embryology field and not come up with one other person that you have in common. That's how
Yes.
small and like, our field is. So we're just a very close knit, it's a small community. There's not that many of us in the United States, let alone even when you talk about international. It's just really not that big of a community. And
Hmm.
so we tend to know everything that goes on in the field. And so every once in a while I hear these stories about like, you hear about things in the media, like, and people, and I'll be honest, I think our field is very good about being very transparent and being very honest, which is great. I'm very happy for that. But those couple little things that have happened over time, like tank failures or something that have happened, those
Hmm.
really make patients worry. And I would say the one thing my advice would be like is don't worry about some of those things. The people who are working in embryology labs, I can guarantee you there are not people working in embryology labs just because it's like some really like lucrative easy job. That is certainly not it. It
Right.
is definitely not a field that you get into because you want like an easy career or
Right.
just like it is not for that because everyone I know who works in this field, they're in it for some other reason. They're in it because they're compassionate about the type of work they do because they love the science, because they really care. It takes dedication. There is nobody who's in this field without the right reasons because it's not an easy. It takes 4 years on average to train to be an embryologist. That's a long
That
time,
is a long time. Really.
and it's very dedicated, very stressful work, but people who do it love it and that's why they do it. So I would say just trust that the people who are behind the scenes are there for good reason and they
Mm.
do, even if you don't see them, if they're just magical people behind there, that there are people who really genuinely care about what's going on and are doing like the right thing and want the best thing for you.
Exactly. And thank goodness that everything is working well behind the curtain, right?
Hmm. Yeah.
How how has the field of IVF evolved?
Oh man, it has changed. So if you think about it, the oldest IVF baby in the whole world is basically my age. So she's just mid 40s, and the oldest one in the U.S. Is actually a good friend of mine. She's actually younger than me. So we've not been at this very long. So the first IVF baby in the whole world was 1978. And so it's really not been that long. And
Not
so
that long.
we went from way back then, taking what we knew from working with animal embryos and what very basic they could try to figure. And that was basically just trying to like naturally go in and get eggs from basically natural cycle type thing. I mean, not even really kind of having like the medications that we have now to stimulate the ovaries. So I would say as far as the embryology field, we've progressed a lot. And at the same time, also the medications and the treatments, as far as for the actual female patient themselves, have progressed. But as far as for embryology, we, so, we went from basically trying to get a couple oocytes that we could, and then just putting as much sperm as we could with them and hope they fertilize. And then at that point, as long as we got fertilization, we were putting back as many embryos as we could at, just maybe like 2 or 3 days after fertilization. And that was kind of how it started in those very early days. Then around the very early 90s, we kind of by accident developed ICSI. So ICSI is where you inject the sperm into the egg.
Mhm.
That really opened things up hugely because we were able to take men with poor and poor sperm quality, and really increase fertilization. We also can take even surgical sperm, so sperm derived from men with very very poor fertility, that we get sperm directly from the testicle even, and inject those into the egg and still be able to get embryos and live births and everything. So that was early 90s. And then, it was still really early. We learned how to freeze embryos. It wasn't until the early 2000s that we figured out how to grow embryos to the blastocyst stage. I already mentioned how that really changed being able to grow, like really changed pregnancy rates, being able to grow embryos to the blastocyst stage really made a huge difference. Then I would say vitrification, which is what we use for freezing now. That's the freeze method. That was like probably around 2010 to 2014 is when that became really popular. And then it was even after that that we really became good at freezing oocytes. It was really only in the last, maybe since around 2015 and on, that we became really good at freezing oocytes. Before then, we could freeze embryos pretty well, but oocytes were very, very challenging. And now we can freeze oocytes really pretty well. They're still more challenging than embryos for sure. But we got to the point where we could freeze oocytes. And now we have all these genetic tests we can do on the embryos. So who knows what we're going to be doing in the next the next few years. I think we'll probably be able to get more, now we have AI technology as well too, that we can use time lapse imaging and we can kind of learn more about, the embryos by machine learning, which is just kind of really starting to take off. My prediction is probably in the next few years, who knows how many, we'll have more that we can learn from like AI type things, as
Mhm.
well as maybe some non-invasive, like maybe something we can measure that the embryo is a byproduct the embryo is putting off. We've already tried that over time, but we still haven't quite kind of mastered that. Like maybe something that the embryo is making in its metabolism, or even there are people that have kind of tried doing non-invasive genetic testing where we don't biopsy the embryo, but we look for kind
Mhm.
of like free DNA and within the embryos, like little dish that they're in. But yeah, I think there's going to be some cool things coming on the market. Definitely, genetic testing is going to just continue to be more and more. There already are some kind of whole genome type things out there where they can tell you more about not just whether they're genetically normal, abnormal, but also. I know there's starting to be some talk about things like, what's the eye color? What's the IQ? All sorts of other things that who knows? There's gonna be more, a lot more out there on the market, and probably not that long. But it'll be interesting to see what happens. We're definitely still a very young field and quickly evolving.
Definitely. It's amazing to hear from you what's transpired through the years, especially through tech. And I can't imagine what's going to unfold for future patients. Switching gears, I like to ask all my guests what kind of things that you like to do for self care or to just decompress.
I I would say, it kind of like has changed over time. I've always been big into like, cooking. We have always liked to travel. I think for me anymore, like, I think things have since I don't do the bench work anymore, I think the bench work used to be a little bit more like physically exhausting for me. And now I'm at a different stage in life where things are not as physically exhausting for me anymore, but it's a little bit more of like a mental exhaustion type thing. So I think for me anymore, I like to just, I like to watch kind of like silly, mindless shows and just kind of like, read and I actually do really like to read scientific journal articles and
Hmm.
I actually, I do kind of do a lot of stuff that is still kind of related to our field, but they're kind of like, not directly related to Generation Next necessarily. But like, for instance, I work with some students through the same place that I did my PhD through, and I work with them on like developing their dissertation projects and and their thesis projects and some of that kind of stuff. Just that like mentoring to me is rewarding, even though it's still kind of like career and work related. It's still just, to me, it's like it's still I'm learning and it's stimulating and it's kind of like interesting for the mind, but it's not just kind of like, it's not directly necessarily work related, but yeah, I don't know. I probably would do better if I did a little bit more relaxing stuff, but honestly for me, I really like a good, I like to lay around and watch Law and Order SVU and relax and get a good night's sleep and eat good food and, travel. That's probably my favorite thing still overall.
Amazing. I'm so glad that you shared these self care insights into what you do, especially since you have such a high pressure job. If there was one thing you wanted people to take away from our conversation today, what would it be?
I would say, I know that it is a really emotional journey to go through for patients. And I hope that whether they are patients of ours or whether they, are patients somewhere else, they do find people that they can connect with, whether it be the people in their clinic. That's the one thing that I do really like about Generation Next. And that's why I am really happy with, my career here is because of the fact that we do have a lot of direct patient care and a lot of that kind of direct patient support. But if they don't have, whether they're not a patient here or they're not finding that in their clinic, I hope that they are finding that somewhere, whether it be through support groups or through family or whether they're doing some other like holistic care. That they're finding some way that they're just kind of getting the emotional support, the self-care, but also they're getting maybe kind of like the education, whatever to them kind of makes them feel better. I know some patients I talk to, and what I know some patients really just want all the information. Like what makes them
Mhm.
feel the best is they basically become embryologists. They want to know everything there is to know about embryology, and that's what makes them feel good in the journey. And even if they don't get good news along the way, it helps them understand the news and then be able to make the next best decision until they finally get those success stories. And then there's other patients who, they really do well with, making sure to like meditate and yoga and acupuncture and things like that. And that's what really helps them. And I think just finding whatever that is for them that helps them in their journey, I think is really, really important, and finding their support system. But yeah, I think persistent and, don't give up the journey until you finally, are at a point. If hopefully it works out for everyone. I, certainly want everyone to reach their goals of parenthood. Um, but, I just wish everyone the best in finding their, their support system and their kind of like path toward that parenthood.
Perfect, and we'll leave it at that. I love, the examples you gave and just how you're giving back to future embryologists potentially down the road. Where can listeners get in touch with you and your preferred social media?
So I think probably the best thing would just be reach out to me through Generation Next. I know we have, yeah, I mean, honestly, just reach out to me through Generation Next. I don't have like necessarily an Instagram through there, but I know that we do have several through Generation Next. So if
Yeah.
they reach out through there, they'll be able to reach out to me. Certainly.
Perfect. We'll include all of that in the show notes. Thank you so much for
Yeah.
sharing your insight and all you do to help build families. It was great having you on with me
Yeah.
today.
Yeah, this was a lot of fun. Thank you so much for having me. Let me know if I can ever join you again for some other topic.
We'll definitely have you back on again. I feel like we just scratched the surface. Thank you
Yeah,
again, Dr. Broussard.
sounds great. Thank you. Take care.
My pleasure.